Assalamualaikum. Hello and good morning to everyone. Welcome to today's webinar's updates in emergency critical care course for paramedics. Before we get started, I'm going to go through some housekeeping to ensure you can interact with myself and the speakers. Firstly, we will have our Q&A session towards the end of each session. If you wish to ask the panelists a question, we have a Q&A feature enabled. To access this, simply click on the Q&A button below. And if you experience any issues in hearing today's webinar, please contact our crew. Their support team will help you to troubleshoot any issues. Ladies and gentlemen, for those who missed our session yesterday, you can watch our recorded video from the YouTube channel and the Facebook page at Malaysia Paramedic Emergency Critical Care Alumni. Please browse through the catalogue shared inside the Telegram group from our sponsor SMS Medical at Sdn Bhd, and please do contact them personally for any inquiries. Please be aware that all e-certificate will be emailed to everyone a week after today's webinar. And please do take note to fill in the feedback form, and then the link will be given after today's session. A gentle reminder for those who not completed the feedback form, you won't be receiving the e-certificate. I repeat, for those who have not completed the feedback form, you won't be receiving the e-certificate. Please be aware and expected of delay while live streaming due to the strength of the telco or internet carrier. Before we start the webinar, and in order to avoid any disturbance during the presentation later, I would like to ask you to change the mode of your gadget into silent mode. The Honorable Mr. and Madam Speakers, distinguished guests, fellow alumni, students, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. First, I would like to welcome you all for the commitment and supporting our second day webinar. This webinar series, held by the Malaysia Paramedic Emergency Critical Care Alumni and co-organizer with Ipoh Emergency Critical Care Society and Institut Latihan, Kementerian Kesihatan Malaysia, IECCS, Sultan Azlan Shah. And most importantly, our sponsor, SMS Medical at Sdn Bhd. Thank you for your support. I would like to take all of you for a brief today's agenda. We will together until 12 afternoon. The sharing session for today, we have 4 panelists with different topics. So we do hope everyone is ready with a pen, paper, and find the most comfortable place for you to watch and listen for the rest of our webinar today. So now, we move to our first panel. She is Dr. Shaliza Shamsudin. She was graduated from University of Malaya. Then she continued her specialties at UKM for emergency medicine. Currently, she is doing a fellowship in emergency and critical care. She also active in publication and research. She is an emergency physician at Emergency and Trauma Department from Hospital Kuala Lumpur, with the title, Bringing ECC to PHC by one and only Dr. Shaliza Shamsudin. Please welcome.
Okay, thank you for the kind introduction, Mr. Chairperson. So, just testing. Is the voice clear? Okay. So, without further ado, okay, for my topic presentation for the second day of presentation for today, I would like to bring you guys to the topic of the bringing emergency critical care to pre-hospital care. Okay, for this session, I'll introduce you about the critical care medicine, and we will discuss a little bit more on the ABC approach to the critical patients incorporate to the pre-hospital assessment and resuscitation. And also I will discuss on the optimization, how we can optimize resuscitation in terms of the pre-hospital, and we can incorporate the critical care medicine to the pre-hospital management. Okay, before I proceed to to discuss about critical care medicine, I just want to define the pre-hospital. So since pre-hospital care is the first personnel that go to the scene, the pre-hospital care is the phase of the care necessary to get a patient from the point of injury and illness to the definitive treatment in which the hospital. And in Malaysia, there are broad spectrum of EMS services exist, ranging from the basic transportation, either from the hospital to the hospital, step up care or down care system, or from the scene to the hospital setting. So second part, they will also provide the basic life support care. And on top of that, in certain hospital, with the presence of the trained healthcare personnel, then they can provide advanced care, such as they can even can introduce and initiate thrombolysis at the pre-hospital. So when you say at the WHO organization in terms of emergency care system, you see on the left-hand side actually is about, we talk about the pre-hospital care. And it basically can be divided into two, either at scene management or during transportation. And the right-hand side, what you can see actually in hospital setting, which is in emergency setting. So as you know that the paramedics that go to the scene will do initial assessment, and they basically the first person they encounter and assess the patient and deliver the resuscitation. You can see from here how we can incorporate the critical care medicine. Previously, we concentrate only ICU care, and because of the evolution of the medicine, then we bring the ICU care or the critical care to start in emergency department. So if you can see from here, delivery of the management started from at first at scene up to the hospital setting, and this should be continued so that there are no gaps in between the management of patient. At the end of the day, what we want actually to deliver the best possible management and resuscitation that we want to decrease the morbidity and mortality associated with sudden medical and traumatic emergencies. Okay, then we talk about critical care. Okay, without realizing that most of the time we are not only resuscitate patient using the critical care management, not only in the hospital like I said, and you basically already started at the pre-hospital. What is ECC? So emergency critical care actually is focused on resuscitation of patient with which is acute, and they have actually is life-threatening, and most of the time the illness is reversible. And early intervention actually is important despite simple measures as simple as airway breathing and circulation resuscitation can improve the morbidity and can improve the survival rate of the patient in totality, and this can reduce the risk of death. Okay, when we talk about goal of the pre-hospital care, so we know that in medicine this is what we want: get the right patient, identify critical ill patient at the correct time, resuscitate them timely and appropriately, and bring them as early as we can to the hospital, and this should be done with the right time. Okay, when we talk about critical care medicine, I think this actually can be done in the remote setting in which in Sabah Sarawak, in which they have the services, what we call is flying doctor services and Medivac. If you compare to us, we basically have each during our transportation time actually is very limited, about 5 minutes up to 30 minutes. And in terms of critical care management, probably much more lesser compared to the patient who actually is delivered from one spot to another spot in which from the secondary hospital to tertiary hospital using the ambulance, using the helicopter, in which resuscitation should be continued from the secondary hospital to the tertiary hospital. Okay, a very interesting articles about critical care. So traditionally, previously, we basically use the critical care medicine only in the ICU. And because of the evolution of the medicine, because of our numbers of patients actually is increasing and increasing amount of critical ill patient, this critical care medicine start to use in emergency department, and we start to do TTM, we start to do post cardiac arrest resuscitation even in emergency department, and we deliver critical care management in the emergency department despite we wait in ICU. And as I said, critical care should be without limit. We need to bring the critical care medicine to the pre-hospital so that the patient can get early treatment, early intervention, so that you can send the patient up to the hospital and can continue resuscitation. Okay. Second, we will go to the and discuss about the ABC approach to the critical ill patient. So I'm sure that you actually familiar with this table. So in terms of resuscitation aspect in the eyes of pre-hospital, I think it is quite similar to the critical ill patient approach. So you basically go to the patient. What you need to ask actually just evaluate the patient airway breathing circulation. Then you can identify the life-threatening condition and intervene if necessary. Then if there is no life-threatening condition, then you go to the next step. Ask yourself if the patient is critical or not. Okay, if patient is possible and potential critically ill patient, then secondary assessment should be done. Either you ask the history, secondary survey, and also on top of that, you need to do some diagnostic procedures such as glucose, ECG, ETCO2. Then after that, we refine the differential diagnosis and divided the patient into 3 categories. Either the patient has life-threatening condition, critical ill patient, or non-emergent, and the intervention and resuscitation should be followed based on the criteria of the patient. Okay, I think this is quite a simple diagram to show that the way how we approach from the pre-hospital and also in the hospital approach actually is quite similar. What we want basically to determine the patient, either the patient have life-threatening condition based on this A, B, C, D, E approach. Okay, I just want to add on the trick and tips to identify the potential patient that might deteriorate in the pre-hospital. And this new score, which is National Early Warning Score, has been established in the hospital as the tool that can guide and to predict the patient who has risk of deterioration and who should be monitored closely and who basically should resuscitate immediately. So this basically consists of 7 simple physiological parameters, include a common parameters that we take every day either at the bedside or at the scene. So basically this scoring system consists of respiratory rate, oxygenation, saturation oxygen, temperature, blood pressure, heart rate, and also conscious level. And you put the patient and score the patient according to the numbers and the degree of severity, and you will do summation of the scoring system. So that is in hospital setting. So can early warning sign score be used in pre-hospital then? So one of the article by the Patel et al. In the systemic review of 17 studies, they also study on the early warning score to identify potential deterioration patient in the pre-hospital. What they found out, a very low EWS score equal to 0 has unlikely to deteriorate during the transfer, and very high score equivalent more than 7 or 7 are more likely to deteriorate and should receive appropriate intervention during transfer to the hospital. Okay, then second aspect, we need to discuss about how to optimize resuscitation and incorporate the critical care medicine to the pre-hospital management. Okay, we look at the airway breathing circulation. Okay, I think most of you know about it. So first, when we assess the patient, the airway and breathing is the fundamental aspect which is important to evaluate first. Either from clinical aspect, from look at the pulse oximeter, what actually is the trend of the saturation oxygen, and on top of that, capnography has a good role in terms of management and monitoring the patient. And EBG analysis most of the time is not feasible to be done in the pre-hospital, but in US and some part of the country actually has been used this EBG analysis to ascertain and manage the patient at even despite in the pre-hospital care. And after clinical evaluation in terms of airway and breathing, then you determine what actually the likelihood of differential diagnosis that you deal with. Okay, you see from here, This is the most common one, the saturation oxygen and ETCO2. Okay, the simplest one actually is to use ETCO2 at any kind of patient. Is not only cardiac arrest, but also in a critical ill patient. A simple basic technique, you just put the circuit, connect into the monitor and read this waveform. So basically from the waveform, what you need to see actually the trend and the shape of the waveform and to see at the ETCO2. Okay, what basically the ETCO2 show actually either there is any possibility of the issues with the ventilation, the perfusion and metabolism. Okay, this is the wave of the ETCO2 during expiration and during inspiration. What basically we measure actually is the ETCO2 at this end of the expiration. So normal ETCO2 is about 35 to 45. And I think I'm sure most of the pre-hospital care use this ETCO2 to guide and monitor the patient. So you look at this case, what happened? Initially, there is a tracing on the ETCO2 and now basically become flat. But if you realize that saturation oxygen is still maintaining at 98. So basically the ETT has been dislodged. And one of the component aspect in the ETCO2 can detect as fast as a 10 second compared to the SpO2. SpO2 will be dropped after 5 minutes of the oxygenation failure. Okay, a very simple technique, okay? You just see at the waveform, normal is 35 to 45. The shape and the plateau should be seen, okay? So in hyperventilation, it will produce low CO2 so that the reading much more lower. If hypoventilation, because of the CO2 higher, so the reading will be higher than normal. And bronchospasm, it also have hypercapnic. And also if you see at the plateau look like a shark fin shape. Okay, how about the usage of the ETCO2 in cardiac arrest patient? Okay, as we know that in OCA, chain of survival emphasize on high quality CPR and how we use the ETCO2. Okay, so what are the goal of during CPR? I am sure you know about it. We need to emphasize the guidelines emphasize on the push hard, push fast, and allow complete chest recoil. So to make sure we deliver a good quality CPR, we use the ETCO2. And despite that, guidelines for CPR and ECC 2020 emphasize more about the usage of ETCO2 during resuscitation aspect. Okay, what are the role of ETCO2 based on this guideline 2020 AHA guidelines? Okay, number one, you can confirm ETT placement. Number two, you can monitor CPR quality. If you see the ETCO2 is less than 10, you know that the quality is not good. So you need to improve until you get more than 10 mmHg, and the best basically if you get more than 20. So also you can use the ETCO2 to detect ROSC. Means that whenever patient arrive, patient in arrest, the ETCO2 reading give about less than 10, and after patient has ROSC, the increment of the CO2 normally is the abrupt sustained increase to a normal CO2 more than 35 basically say that this patient has ROSC. And despite that, there are extra component in the cardiac arrest that you can use ETCO2. You can terminate even the resuscitation if the ETCO2 remains less than 10 millimeter mercury after 20 minutes of resuscitation. Is that patient actually has a very low chance of achieving the ROSC. Okay, you can see from here, the tracing of the ETCO2 is really good. It's about 35 to 45. You know, this is a good quality CPR. Then you also can use, as I said, to detect the ROSC. At first, when patient has patient ETCO2 is low, then when patient has ROSC, you see that the ETCO2 increase dramatically to the more than 10 millimeter mercury. And you can also use the ETCO2 in asthma and COPD. What you see actually the shark fin appearance, the more degree the angle of the plateau, this is equate the severity. And despite that, after you give treatment to the patient, you can see the shark fin become reducing and the plateau become much more horizontal and the ETCO2 remains normal. Okay, second, we go to a case scenario. Basically, you go to the scene and you encounter a patient, 84 years old male with a complaint of shortness of breath for 2 days. And on a quick assessment, that as usual that you do in the pre-hospital, airway, breathing, circulation, what you found out that the patient is tachypnic, patient actually is in respiratory distress, hemodynamically slight hypotensive, and you know that the patient has a long list with medication, include the GTN and furosemide. What are your concern? So I think in most of the time when you encounter a patient with shortness of breath, our concern is still airway, breathing, and circulation. And this patient has saturation oxygen of 90. So what we need to do next? So I'll talk on the NIV in the pre-hospital. It is important modalities that has been used in the pre-hospital for any patient in moderate to severe dyspnea, especially in the cases of acute pulmonary edema, COPD, and asthma exacerbation. And studies have shown that this NIV in the pre-hospital usage decrease the need of intubation and relieve the symptoms. Means that after you give a CPAP, patient less work of breathing, RR reducing, SpO2 increasing. Okay, what actually is method that we can deliver through the NIV? It either CPAP or BiPAP. Okay, commonly we use the Buzenex CPAP, but because of COVID era, like we discussed yesterday, because of aerosolization risk, so the CPAP actually is quite limited. Then we change to use of the helmet. However, if you don't have any helmet CPAP at the pre-hospital, you can modify, put the filter on top of the mask, and you can deliver the CPAP. Okay, what basically it help? Okay, as you know that in pulmonary edema, because of the fluids fill the alveolus become collapsed. And what happened? It prevent the oxygenation and it will alter the ventilation. So because of the PEEP deliver the positive pressure to the alveolus, it make the opening of the alveolus. And this basically can improve the oxygenation and ventilation. Second part, we talk about shock. So as you know that shock is very important things that we need to identify. Okay, when you deal with shock patient, there are 3 components that you need to look for. Okay, not only the blood pressure, you will not only to look at the heart rate, but we need to know what is the cause of shock. Okay, we talk about shock, we need to think about preload. If the preload is low, if the patient is hypovolemic, or if patient is dehydrated, so this basically can alter the preload. And second, we see at the heart, is the heart function is bad, it can cause cardiogenic shock. And how about the afterload? Afterload basically in the case of sepsis in which they have a pronounced vasodilatation and cause reduce in cardiac output. How to get the perfusion monitored then? Okay, as I said, start with clinical. You can use the non-invasive blood pressure monitoring. You can use shock index. You can use monitoring of the paraphrase. And also you can use the cardiac monitor, look at the arrhythmias, look at the potential ST elevation MI and ischemic changes in the ECS. And IABP, which is not common to be used in here, but in the critical care outside, critical care paramedics in outside, overseas, they use the IABP quite a lot. Okay, and the last one, the POCUS, which can evaluate what is the type of shock that we deal with. Then after that, after assessment, we come into the conclusion, patient has shock, then we need to deliver the resuscitation. Just to mention that not all shock require fluids. That is why identification and the treatment of the shock should be based on the potential underlying shock cause. Okay, when you deal with shock patient, the question is how to diagnose what type of shock patient have. Okay, either distributive shock. Distributive shock, we talk about vasodilatation in sepsis, obstructive shock in the patient with a cardiac tamponade tension pneumothorax, patient hypovolemic, quite common in the hemorrhagic in trauma, and cardiogenic shock. And different shock will need to resusc according to the type of shock. Okay, how to evaluate? So I want to bring your attention to this usage of POCUS in the pre-hospital, because we can determine what type of shock that patient have. After you determine that patient have shock, do POCUS, then you can evaluate more about the type of shock. You see at the pump, you see at the tank, you see at the pipe, and then you know what type of the shock that we deal with, and the management will follow. Let's say if patient have hypovolemic, you give fluids. If patient is in acute pulmonary edema in cardiogenic shock, don't give fluids, but you need to give other medication. In the hospital, we use vasopressor. And then if the patient have leaking because of aortic dissection, aortic aneurysm, then you can play around with fluids resuscitation. Okay, then what is the role of the POCUS in the pre-hospital? Okay, we can use the pre-hospital, the POCUS in the pre-hospital to do these three components. Okay, number one, you can differentiate PEA and pseudo-PEA because most of the time after patient has ROSC, you can't even palpate for the pulse. You don't know either patient have a good pulse, either patient have pulse to determine either patient is has ROSC other than you see at the ETCO2. So this basically can do as an adjunct to differentiate PEA and pseudo-PEA. And also, you can identify treatable causes, common cause in the cardiac arrest, tension pneumothorax, cardiac tamponade, massive pulmonary embolism that you can treat at the same time when you do POCUS. Okay, this is the recommended approach. There are a lot of protocols out there about the usage of the POCUS in the pre-hospital. You can read about it later. Okay, so we see at the emerging standard care. Nowadays, we change because of the evolution of medicine, there are a lot of things that has been changed. There are a lot of evolution in terms of the technique and also the modalities that we can use to resuscitate the patient. Okay, like yesterday, Dr. Yong already emphasized on us on mechanical CPR and also post cardiac arrest in terms of the TTM. So, and also we need to look at the advanced airway management. In the UK, what they basically skills under advanced care of patient and the paramedic skills that have been emphasized is to perform RSI, and also some of them can even perform the cricotarotomy. Okay, when you look at the evidence about the TTM itself, recent AHA 2020 recommended the TTM should be performed in the hospital under recommendation A, 2A and 2B. However, when you look at the pre-hospital evidence in terms of TTM, there is no benefit to perform in the pre-hospital. Why? Most of them basically start the had rapid infusion of cold IV fluids that actually initiate or cause acute pulmonary edema, and because of that TTM is not recommended. I think in future what we need to look for basically the cooling method other than just rapid infusion of cold IV fluids to limit the component of the complication because of the IV fluids. Then second one, other than basic airway, you can perform advanced airway even in the pre-hospital, either supraglottic airway, which you normally do, or intubation if we have been training, we had a proper training on the RSI method. So these are all the skills in the under advanced paramedic skills in the Canada, US. They have a lot of range of the skills that can be done by the paramedics in terms of critical care medicine. Okay, take home message. This will be my last slide. Okay, so for the take home message, we need to incorporate the element of critical care to the pre-hospital. That is number one, because critical illness is common. Identification early, we need to resuscitate early and monitor them appropriately. Not only looking at the hospital, the seamless, the management should be started at even in the pre-hospital, continue even in the hospital. Simple treatment can make a big difference. You need to know what to deliver in terms of airway breathing circulation, optimized resuscitation, and one thing we should not forget, critical care should be without limit, critical care without walls. We are not only concentrate the critical care at the pre-hospital, but we also need to incorporate the critical care element to the pre-hospital management. Okay, with that, this is my end of slide. Thank you.
Okay, thank you, Dr. Shaliza Shamsudin, for the great sharing. So if there are any question for Dr. Shaliza from the audience?